Hello, friends. Today we'll talk about management of ARDS patient. We all know ARDS is a syndrome. It's not a disease. So it's what is important is that is timely escalation of treatment and the precision ventilator strategies. Allow me to share my slides, please, and we'll discuss about how I manage ARDS step by step, case-based ICU management. I'm Dr. Bharat Jagiasi, Director of Critical Care Department, Kokilaben Hospital, Navi, Mumbai. I'm Examination Secretary-elect, Indian College of Critical Care Medicine. I was past General Secretary of ISCCM. So we all know of these terms. In 1973, there was barotrauma, followed by volutrauma, atlectrauma, ergotrauma, and the ventilator-induced lung injury. So what ARDS is basically injured lung due to any primary disease, or it could be because of the lung as well. And eventually, ventilator is known to cause harm to the disease. And ventilator is known to cause harm to the lungs when the patient is being ventilated at the wrong pressures. So already injured lung will worsen if you ventilate them in wrong way. So look at this. This is the ultrastructural appearance of blood-brain barrier after 5 minutes and after 20 minutes of mechanical ventilation at 45 centimeter of peak airway pressure. So in the initial part, if you see, there's just blood or there's diffuse damage to the basement membrane. And if you go into the later part, there's totally alveolar hemorrhage, interstitial edema. So this is what ventilator does to us. If you look into the gross appearance of the lung as well, in normal lungs, then what we see at the 5 minutes and what we see at the 20 minutes or the 45 cent when the lung was ventilated at 45 centimeter of peak pressures. So let's take a case now. So it's 42-year male, history of cough, fever, and progressive breathlessness. He's non-smoker, no comorbidities, and HRCT showed bilateral ground glass opacity. If you look into the ABG, PaO2 on room air is 58 millimeter mercury, and PF ratio is around 276. So what we look into the ARDS, first is define ARDS, whether we have to see whether this patient fits into the criteria of the ARDS or not. So if you look into the Berlin definition, it has 4 components. One is about the onset of the disease, that is within 1 week. Yes, the case fits into the same. Then we have the bilateral opacities on the chest imaging. Yes, those were there. Respiratory failure, which was not explained by cardiac failure and the fluid overload, and the PF ratio less than 300 when the PEEP was more than 5 centimeter of water. So when it comes to the Berlin definition, PEEP is very much important. And this is why the ISCCM expert group in 2023, when they made a guideline, when they came up with new guidelines, they proposed there should be something as well where we should be able to define ARDS without the patient being on the mechanical ventilation. Although this was about the definition. Now about the severity classification. So it's been classified as mild, moderate, and severe. Is mild when the PF ratio is in between 200 to 300, moderate when the PF ratio is in between 100 to 200, and severe when the PF ratio is less than 100. Why is it important? Because the mortality increases with severities. Around 35% in mild cases, approximately 40 in moderate, and 46% in severe cases, despite of all the advances what we being using now at this stage. So this is where the new definition came in, which in terms of timing, almost it remains the same. When it about the imaging, if you see, they have added the lung ultrasound to look for the bilateral B lines. Classification, they've also added the SpO2, FiO2 cutoff for the resource limited setting. And it was about the PEEP mainly. So because HFNC was more used in the COVID and we've been using HFNC in ARDS. So as per the Berlin definition, as we don't apply PEEP in the HFNC, a patient could not be defined or labeled as an ARDS patient. This is where the new global definition, they brought up a flow rate of more than 30 liters per minute if the patient is receiving HFNO. So even if the patient is an HFNO, as per the new global definition, we can classify that patient as being we can define that patient as being on the ARDS patient. So of course, this patient meets the Berlin definition criteria, acute onset, bilateral infiltrates, no cardiac cause. So, and the PF ratio somewhere around between 200 to 300. So it fits into the category of mild ARDS. So we all know the ARDS management considerations a heterogeneous disease, so non-homogeneous lung involvement, variable lung compliance, and there's a risk of further inducing ventilator-induced lung injury. So when it comes to the mild ARDS, so there are recommendations we can use the non-invasive ventilation or HFNC in mild to moderate ARDS patients. This is what is known to us. But when we compare the CPAP versus IPAP or the CPAP NIV versus the conventional oxygen treatment therapy. So what we look into is, and what are the recommendations by the ASM 2023 guidelines. So they have not made any recommendation when it's between the CPAP NIV versus the COT, that is conventional oxygen therapy, because of high level of evidence for mortality and moderate level of evidence of intubation. So panel suggests the use of CPAP or NIV or conventional oxygen therapy to reduce for the treatment of AHF. They are unable to make any recommendation to reduce mortality or prevent intubation. But in case of the COVID, there's a weak recommendation which is in favor of reducing the risk of intubation, but was not in favor of, there was no recommendation when it came to the mortality. So now they compared high flow nasal cannula versus NIV and CPAP. So because we've been using HFNC quite well since the COVID times, we were using before that, but the number of patients and our comfort level is gone after the COVID era. And when they compared, so they did the HFNO versus NIV. So if you look into this, there was an equivocal role when it comes to the mortality and the intubation. And this is the reason why they were unable to make a recommendation for or against the use of HFNO compared to the CPAP or NIV to reduce mortality or intubation in the treatment of unselected patients with acute hypoxemic respiratory failure, not due to cardiogenic pulmonary edema or acute exacerbation of COPD. So no recommendation because of moderate level of evidence for mortality and low level of evidence for intubation, not in favor or against. But panel suggests in CPAP and IV can be considered instead of HFNO in case of ARDS due to the COVID-19 to reduce the risk of intubation, but no recommendation was made when it was related to decrease the mortality. So what is the baseline? When the patient comes to you, initially you define and see whether the patient fits into the Berlin or the global definition of ARDS, label that patient as ARDS, and classify ARDS into mild, moderate, and severe. Mild to moderate ARDS, we can try the HFNC or the NIV therapy, and we can monitor those patients closely because it's very high chances ARDS is a syndrome, the disease will progress, and there will be a failure of the HFNC and NIV. And we cannot continue ventilating those patients for the longer duration because there's something called as SILI, that self-inflicted lung injury, because patient is breathing heavily, there's lots of stress and strain, and that further induces the damage to the alveoli. So it's very important to take a timely decision and escalate the therapy if patient is not doing well on the HFNC and NIV. So how do we do that? So we have the measures like we do ROX index or HECOS score, and we have to do it hourly basis or 2-hourly basis. And if next 3-4 hours, the patient is improving, we'll continue with the existing therapy. And if the patient is not improving or worsening, we might consider escalating the further therapy and intubating that patient further. So of course, when the CPAP and NIV was also compared, panel was unable to make a recommendation for or against the use of NIV compared to the CPAP in the treatment of ARDS. And even in the CPAP and NIV, in some cases, helmet was used and it was supposed to be giving the positive result. But when it comes to the studies, helmet was not proven to reduce the risk of intubation or mortality. So this patient was started on HFNC and the FIT was 50 and the flow was 40 liters per minute. Intermittently, NIV trial was given and maybe the helmet was fitted, and we were monitoring this patient for the bursting of oxygenation. And this is what the ABG came in. So PO2 has dropped from the mild category of ARDS to the moderate category of the ARDS, severity of the ARDS. So it's a worsening PO2. So what do we do next? Of course, the progression is to the moderate ARDS. This patient is not doing well. And as we all understood, the management of ARDS is mainly about oxygen support, non-invasive ventilation, followed by the invasive ventilation. So of course, this patient will go for the intubation. And once we intubate this patient, the main thing which comes in, how do we ventilate? So protective lung strategy, also known as the open lung approach, is the standard care of management of patient with the ARDS. And it's a combination of low tidal volume ventilation and application of PEEP above inflection point. So how do we do it? This all came up with the 2000 when the paper was published in NEGM, which always spoke about the low tidal volume ventilation. There was reduction in 9.9% on the absolute mortality with low tidal volume. And when it was compared 6 ml versus 12 ml per kg of predicted body weight, and we have to maintain plastic pressure less than 30 centimeters of water. And the number to treat, which was required, was 11 patients to prevent one death. So based on this, strong recommendation were made by an expert opinion for low tidal volume, that is somewhere around 4 to 8 mils per kg of the predicted body weight compared to the larger tidal volume to reduce mortality in ARDS. And we can't do the further more studies in it because this has become the standard of care. Though the evidence is only one, there's one major study with this, but again, it's very unethical to go ahead and do further studies because we all have seen this works very well, and this has now become the standard of care. So because there's a one major study, the evidence was moderate, but the expert opinion gave us a very high level recommendation for this. And how do we implement it? So we have a different formulation to predict the ideal body weight. The target somewhere around 4 to 8 mils per kg of the predicted body weight. Tolerate permissive hypercapnia, allow pH more than 7.20, and we have to prevent the ventilator asynchrony by using deeper sedation or in some cases the neuromuscular blockages as well. So select any ventilator mode, set the settings at around 8 mils per kilogram of predicted body weight, reduce tidal volume by 1 milligram per kilogram at intervals of 2 hours or more than 2 hours until we reach the tidal volume of 6 ml per kilogram predicted body weight. Set the initial rate to borderline, initial respiratory rate to approximate baseline minute ventilation, and adjust VT, that is tidal volume, and RR to achieve pH and plateau pressure goals. So once we reach 6 mils per kg, and if that 6 mils per kg pH P plateau is more than 30 centimeter of water, then decrease tidal volume further by 1 ml per kilogram in a step till we reach 4 ml per kilogram. Or otherwise, if we are at 6 ml per kilogram and our plateau pressure is less than 25, then increase your tidal volume by 1 ml per kilogram till we reach the 8 milligram. So the ventilation is somewhere in between 4 to 8 milligram. We don't tend to go beyond 8 milligram, and we don't tend to go less than 4. We don't tend to go more than 8 mils per kilogram, and we don't tend to go less than 4 mils per kilogram. So once we ventilated the patient, selected the tidal volume, now we decide what the PEEP is going to be. So we know this, we have the low over PEEP, higher FiO2 chart, and the higher PEEP and lower FiO2 chart. So these are the two charts which are available in the ARDS-net, and we have to set our PEEPs according to these charts. So if you look into the various studies, we have the alveolar studies, which was published in 2004 in NEGM, and we looked into the moderate and severe ARDS, high PEEP chart versus the low PEEP chart, and the mortality was the outcome which we're looking at, but there was no significant difference. Same was also true in the LOVES and JAMA, and also true in the Express JAMA, which was present in 2008. But when it came to the meta-analysis, which was published in JAMA in 2010, which pooled the cases from alveolar, LOVES, and Express, and higher versus lower PEEP was studied in relation to the mortality, what they found was higher PEEP protocol supported in moderate to severe ARDS only. So maybe though the studies are not in favor, and maybe the ESICM guidelines per se do not recommend you, do not advise for or against PEEP titration with a higher PEEP FiO2 strategy versus a lower PEEP FiO2 versus strategy to reduce the mortality. But as per the meta-analysis, we might consider the higher PEEP strategy in moderate to the severe cases of the ARDS. So this was about it. But there are different ways of also to identify the PEEP. So either one is simply we follow that chart, or we do a compliance guided PEEP, that is increased PEEP to the point of best compliance, or we do the esophageal manometry based on the transpulmonary pressure, which guide us to maintain positive transpulmonary pressure, or there's a novel bedside method, that is the recruitment inflation ratio, which tests for the recruitability, identify recruitability, and consider high PEEP and recruitment manner when the recruitment inflation ratio is more than 0.5. So PEEP can be titrated like various ways. We can also look into the stress index analysis of pressure time curve during constant flow. And we already spoke about the esophageal manometry. We can also look into the electrical impedance tomography, that is real-time monitoring of the regional ventilation, which tells us which zones are getting hypoventilated and which zones are getting overventilated, and we can balance over distension and the recruitment. So this is a PV loop. As we understand, we have to keep PEEP 1 or 2 plus above the lower inflection point. And beyond the upper inflection point, there's an over distension. We always keep our plateau pressure less than 1 or 2 less than the upper inflection point. Now let's talk about the recruitment manuals. So we all know this ART trial where the high recruitment manual versus a recruitment manual that is high P versus a low P was compared. There was an increase in the mortality, increase in 28-day mortality in the recruitment round, and higher rates of the barotrauma and hypotension. And when we pool the meta-analysis of the various studies, there's no mortality benefit with the routine recruitment. That means we do not perform recruitment routinely, as the potential harm is there in the unselected patient and the significant hemodynamic complications which have led to death while recruiting the patient. So if you look into this the overall pooled analysis, there's a harm, increase in the mortality when we do the recruitment manuals, and also there's increase in the risk of barotrauma when we practice recruitment manuals. So this is the reason why panel recommend against use of prolonged high pressure recruitment manuals. When we talk of prolonged, that means more than 1 minute high pressure recruitment manuals to reduce mortality of patient with ARDS. And same is true for the brief pressure, high pressure recruitment manuals. Brief is when it is less than 1 minute. So panel do not recommend against routine use of prolonged or brief high pressure recruitment manuals to reduce mortality in patients with ARDS. So when they do not recommend routinely, so we do it selectively in recruitable lungs. So how do we find out? Why do we do it? Because we have to avoid hemodynamic instability, barotrauma. And how do we find out recruitability? As we spoke, there's a novel method of recruit inflammation ratio. There are various ventilators which runs through the software and tells you whether the lung is recruitable or not. So this is one of the methods which what we do. If the RI ratio is more than 0.5, that means lung is recruitable. We can go ahead and practice with the recruitability. If the RI ratio is, that is recruitment to inflation ratio, is less than 0.5, then it is low recruitability. Not driving pressure. It's a critical physiological target, and this was published by Amato in NEGM. So this was actually a pooled data analysis of the previous study. So it cannot be compared with the prospective trials. And what exactly the driving pressure is, it is plateau pressure minus PEEP, and it represents the tidal stress applied to the lung. That is, we apply tidal volume as per the compliance of the lung, and it's a relationship between the tidal volume and the compliance. So if you look into this, the upper charts where the PEEP is constant and the plateau pressure is going high. So hence the delta pressure, that is the driving pressure, is going high. If you look into the corresponding chart downstairs, the mortality is going up. In the middle chart, if you see as the plateau pressure is going up, PEEP is being adjusted to maintain the constant driving pressure. And if you look into the mortality chart, the mortality is constant. Then the next chart, if you look into this, the plateau pressure is constant and the PEEP we are going up. As a result, delta pressure is decreasing and the mortality comes down. So of course, in the retrospective analysis of the various studies, when you look into this driving pressure, we realize driving pressure is related to the mortality. As the driving pressure was going high, the mortality went up. If the driving pressure was stable, the mortality remains stable. And as the driving pressure was going down, the mortality was going down. So this is about the secondary analysis of the 3,000 patients as we spoke, and the delta pressure was variable and most strongly associated with the survival, and it was effective independent of the tidal volume and the plateau pressure. And this is again the macroscopic view. You can see where the driving pressure was 14, 35, 35 and 45 centimeter of water. The lung damages goes up further and further. So movement driving pressure goes beyond somewhere around 14 to 15, the mortality really shoots up. And this is why we tend to maintain driving pressure whenever it's possible, less than 14 and 15. Now, despite all these ventilator strategies, so we had the patient who had mild ARDS. We started with the NIV and HFNC, and FiO2 went down, patient worsened. So we tend to intubate that patient. We now practice that low tidal volume ventilation with appropriate PEEP. We spoke about the recruitment manuals. Also, we spoke about the driving pressure ventilator strategy. But still, this patient didn't do well. Now the PF ratio is further dropping. Now it's coming to the moderate ARDS category still, which is around 130 of the FiO2. So what do we do next? We consider proning in this patient. So what proning exactly does is improve ventilation perfusion matching. It's more homogeneous distribution of the ventilation and reduce dorsal lung compression, and is very good in draining of the secretion, reduce incidence of villi through more uniform stress distribution. It's been studied in a PRO-SEVA trial where the 446 patients with severe ARDS when the PF ratio less than 150 was studied, and the proning was done for 16 plus hours, and there was an absolute mortality reduction of 16%, which was 9%, 9.9% the low tidal volume. So it's better than the low tidal volume strategies. And there we needed 9 patients to save 1 life. Here we need 6 patients to save 1 life. So it's very important strategy. And this is the reason why the panel recommend using prone position as compared to the supine position for patients with moderate to severe ARDS. And when do we do it? When the PF ratio is less than 150 and the PEEP is at the PEEP somewhere around 5 or more than 4 to reduce the mortality. So panel recommend starting prone position in ARDS patient, receiving invasive mechanical ventilation. We all talk about when do we do it. Early after intubation. Early means after a period of stabilization, when the low tidal volume is applied and the PEEP has been adjusted, and the end of it, still the PF ratio remains less than 150, proning should be applied for prolonged session. That is minimum 16 hours or long, and we don't know, but it should be minimum 16 hours to reduce the mortality. And same is also true for the COVID patients. So strong recommendations when the PF ratio is less than 150, it was in favor in the test group, and it should be done early after intubation. Early is when moment you intubated the patient, you apply the low tidal volume strategy, you set the PEEP, and still the PF ratio patient is hemodynamically stable or patient has been made stable on the vasopressors inotropes, and still the PF ratio is less than 150, straight away go for the prone ventilation and prolonged session, that is 16 hours or more. When to stop, we need more studies to study about it. How about the neuromuscular blockage? We all know whenever the patient is on high mechanics, very high P, when you prone the patient, we all tend to routinely start with the neuromuscular blockage agent. So we had the Accurus trial, which used atracurem and which showed benefit when the routine neuromuscular blockage agents were used versus the Rose trial, which told us routine use is not required. So hence, because of there's a 10 years difference in between the two trial, and we have the very good sedative agents which are common. So now we tend to sedate our patients very well. And this is the why there's no recommendation again the routine use of continuous infusion of NM-base in moderate to severe ARDS patient, and also not in the ARDS patient. So it's as per the physician discretion. So the ideal situation is you maintain the patient on the sedation, allow a good sedation over there. But if there's still an asynchrony or dysynchrony despite the patient being on an adequate situation, that is the reason where, that is the case where at the physician discretion, we can consider using NMB infusions. So all this was done, patient is worsened further, PF ratio went down to 16, and now what do we do? It's a refractive hypoxemia. So we look into the Murray lung injury score. So it has various components, and how do we calculate it? So add the individual scores of each parameter and divide it by the number of components we have used. So when the Murray score is more than 2.4, we consider it for the ECMO. If we are not doing this, more on the patient with the PF ratio less than 8, despite optimal management, high plateau pressures and high driving pressures and hypercapnia with acidosis, those are the patients, even if we are not calculating the Murray lung score, consider those patients for the ECMO. So why this recommendation is come from the Elolia trial, where the 249 severe ARDS patients with PF ratio less than 80 were studied versus the conventional ventilation, and there was 11% reduction in the absolute reduction in the mortality. So consider ECMO when the PF ratio is less than 80 for more than 6 hours, despite optimization of the therapy, or the PF ratio is less than 50 for more than 3 hours. When there's an acidosis, hypercapnia, respiratory acidosis, pH is less than 7.25 with PCO2 more than 60 for more than 6 hours, the Murray score is more than 2.5 or 3. What are the contraindications? These are relative contraindications, they're not absolute one, because the prognosis will be poor in such cases. The patient is on mechanical ventilation already for more than 7 days at high settings. That means damage has already happened. This patient might not improve, but again, this is not an absolute contraindication. Patients on major immunosuppression, patient who has a recent major CNS bleeding, reversible terminal condition, advanced age, poor function status. These are the patients where we might not consider ECMO. So looking into all this, panel recommended ECMO, a change from the prior guideline, based largely on the recent Elolia, though reported lower mortality in patients randomized to ECMO, but the finding was not statistically significant. However, the post-hoc Bayesian analysis and the panel's pooled estimate both suggested the ECMO reduced the mortality, and this is why the recommendation came in and there was a change in it. So what we studied in the ARDS patient? First, we had to define the patient. Let's fit the category of ARDS. We had to classify it into mild, moderate, and severe. Try non-invasive ventilation in the mild to moderate cases. Observe very closely, monitor very closely. If patient doesn't improve or worsens, go for the invasive ventilation, low tidal volume ventilation strategy with set PEEP, optimized PEEP. Routinely recruitment is not practiced. If at all you have the gadgets to look into whether the patient is recruitable or not, use that, and if it's recruitable, try to recruit that patient, but observe very closely, because there could be a barotrauma, hemodynamic instability while you're recruiting the patient. If patient worsen further, or in spite of patient being ventilated and PF ratio, despite all the ventilator strategies, you're not able to maintain PF ratio more than 150, go for the prone positioning. Whenever you prone it, prone minimum for 6 hours, consecutive 16, prone minimum for consecutive 16 hours, not less than that. And still, if your patient worsens and the PA pressure is less than 80, consider ECMO. And always ECMO should be referred to the ECMO centers as per the criteria which fits in for the ECMO centers, because the prognosis and outcome is better when the patient is being, when the ECMO is done in the standard ECMO centers. So this is all about it for the ARDS patient. This is the chart and how do we practice it. And also a word about the permissive hypercapnia. So in acidosis management, we need to maintain a pH somewhere around 7.15 to 7.3 and increase RR until the pH is more than 7.3 and the PaCO2 is less than 25. Maximum RR, what we could set is somewhere around at 35. If the pH remains less than 7.15, we might, and RR is at 35, that is respiratory rate is 35, we might consider increasing the tidal volume by 1 ml and sacrificing the PEEP at target of 30. Alkalosis management, decrease ventilation rate as possible. I ratio goal, recommended that duration of inspiration be less than the duration of the expiration. So key evidences, low tidal volume, higher PEEP, prone positioning, target driving pressure, consider ECMO if refractory hypoxemia. And the learning points are ARDS defined stepwise, classify it in mild HFNC versus NIV, moderate intubate, use ideal PEEP, recruitment plus or minus neuromuscular blockage agents as well. Severe ARDS prone early and the refractory ARDS refer it to the ECMO center. These all are the references where I constructed my talk from. Thank you for listening. Thank you very much. Keep listening. Kindly subscribe to my YouTube channel and share this talk with your friends to spread the knowledge. Thank you very much.